using individual physicians or hospital-only methods. It clarified EMS-specific security and storage requirements and administration under verbal and standing orders or medical protocols. Those definitions were added. And some stuff regarding restocking controlled substances and documentation and record keeping specific to EMS. The good news is that after going through this rule in pretty much detail, it seems really straightforward and it's clarified a lot of questions we've had over the past few years. And it pretty much doesn't outlay any brand new requirements or concepts that EMS, paramedic level EMS agencies weren't already following. So Dr. Sandy is going to speak more about that here in just a little bit. I believe he's logged on. Yep, Dr. Sandy is logged on. So I'll be turning it over to him in just a few minutes to kind of go into more depth about the rule and how it affects medical directors and paramedic providers and agencies. But part of the things that we did is we made a little adjustments to the image trend elite PCR. A lot of you probably have already encountered that if you have charted administering DEA controlled medication in the past week using the elite software. You may not have even noticed it's there because it's really, really easy. Takes about 10 seconds to do it, but it automatically puts your PCR in compliance with some of the new DEA regulations. What we did is we went through the entire formulary that is in Elite, and we identified all the medications in there that are DEA Schedule 2 through 5 medications that will require some additional documentation. Once we had those identified, we opened up 2 new elements, as in the type of physician authorization and the physician that did authorize the medication. And those are now auto-triggered. So if you put in fentanyl, those 2 extra boxes will pop up for you to fill out. And I've got Jim Adair on the call. He's our image trend PCR administrator, and I'll get him to show you that, how that will work kind of in real time from the provider's point of view. Are you keyed up and ready to go, Jim?
I am ready to go, Jathan. Shall I share my screen?
Yeah, take it away.
Okay. All right. Good afternoon, everyone. Can you see what appears to be an image trend window in front of you? Okay, I got a thumbs up. We're using our Nemesis demo agency, but what I want to do is just run by what it looks like when you're creating a new incident. So I'm going to go in here much like you guys do. I'm going to speak about those of you that have vendors for your ePCR software, but for now, this is those that use image trend product. You go into incidents and you get your default run sheet. And we let it load up here. I won't run through everything. There's really only one part, and that's the medications, which is in provider actions and medications. And this medication given is what dictates everything. I added these 2 new fields, e-medications .11 and .12. And as Jathan mentioned, that's the medication authorization and the medication authorizing physician. To keep these streamlined, I used visibility rules to hide those 2 fields. The only time they'll show up is when someone goes up into a medication given and chooses one of the 10 Schedule 2 drugs that we've got on our formulary. So I'll come and find one here. Let's see. Diazepam is one of them. And I want you to notice when I click diazepam, these two other fields show up now because one of these controlled medications was chosen. If one of those 10 is chosen, these two fields will show up. There's 4 options here: the online remote verbal order or the standing protocol, any of these, whatever is applicable. And if this is blank, you can just put in your medical director. It's that simple. And if there are no controlled substances, those fields disappear. So you only need them when you choose a controlled medication, and it'll show up automatically. There's one other item I wanted to show you, and that is how to default that value for the authorizing physician. If you use a system run form, you don't want to do that because every other person and every other agency that uses a system run form will get that same default, and they can change it to someone else. So I wouldn't recommend it. But if you've got a custom run form, if you're an agency that has a custom run form, you go to Tools and Form Manager. And in this case, like I say, I've got our demo agency, and this would be the run form that we've got. So you find, again, the provider actions and the medications, and open the medications grid, and you'll find these 2 new values. This is the one that has a default. And if you want to default it, you just highlight this field, and you come down here to the default value, and you just type in whatever your medical director would be. And that's it. You click out of that, it saves it automatically. And so the next time you go in there, your defaulted medical director will automatically show up. Now, if it does that, I've got this saved now. I want to go back real quick to our incident again and show you that that default will show up. Provider actions, medications. We add a controlled med like that, and it would show up. And this is where I guess it didn't have time to save, but Dr. Sandy, because I added that, would have automatically appeared. Had he done that, I can always go in and overtype it with somebody else. So you can change the default, but even if you have a default, you can overtype it here. That is really all there is to it. It's that clean and easy. That's all there is from a PCR point of view. Are there any questions? Hearing none, Jathan, I'll give it back to you and I'll stop sharing.
I think there's a question. Who's got their hand up? Yeah.
Okay. There's a question up?
Yeah, Richie was asking, do that one more time. Which part do you want to see? The default?
Yes, the default, please.
Yeah.
Show the default. Okay.
Yeah.
You're going to go into Tools, into Form Manager, and then you're going to find your run form. And from your run form, you go into your provider actions, and then select medications, and open the medication grid. And you'll go down here to this one, medication authorizing physician. and just highlight that field. And when you do, this stuff opens up. And this is where you can type in your default value. And when you get back out of it, it'll save. But since it was already saved, it didn't need to. Is that clear? Should I run through it one more time?
That's perfect.
Okay. Other questions?
Okay, thanks, Jim. I think that was pretty straightforward, and just following that extra 10 seconds to fill out those new elements brings your PCRs into compliance with the new thing that the DEA has requested. So, any questions so far about anything we've kind of gone over before I turn the discussion of the details of the rule over to Dr. Sandy?
Jason, I just had one more comment. I wanted to mention to the those that use a vendor product. We had to create a new schematron, new validation rules for this, etc. That schematron has been sent to NEMSIS. They have to review and publish it. But I expect the vendors should have access to that new schematron within a day or two, and they could get on board as well. Their interface is going to obviously be different from what I just showed you, but they should be able to incorporate those rules as well. That's it. Thanks.
Awesome. Thanks, Jim. So without further ado, Dr. Sandy, I'll let you kind of take over and kind of walk us through the heavy hitters of this new rule.
Cool, guys. Do you hear me okay? We're going to go, want to go through this just a little bit, understand some of the background on this regulation. So back in 2011, there was a lot of discussion from the DEA, and Idaho was pretty sheltered or isolated from this discussion. But what was happening was that there were DEA offices. You know, we have an office in Boise, but we're out of the Seattle region. There were offices, particularly in Texas, that were telling EMS agencies that, number one, they had to have a DEA registration for every single ambulance if any narcotics were stored or controlled substances were stored on that ambulance. And so, you know, that was a lot of consternation and a lot of questions on what was going on with that. Shortly thereafter, the DEA came out and said, you know, the Controlled Substance Act, which is federal law, actually does not allow paramedics to give any controlled substances unless the physician has specifically prescribed it for that patient. In other words, a paramedic could not give a controlled substance by protocol. And they basically said that in order for a paramedic to give a controlled substance, a physician was going to have to get on telemedicine and talk to the patient and then prescribe that controlled substance specific for that patient. And that's why the act is called the Protecting Patients' Access to Emergency Medication Act. Because the DEA, they're a law enforcement agency, and basically they came right out and said, it's not our job to help you guys figure this out, it's our job to enforce it. And we think we're going to actually start enforcing that EMS agencies can't do this. So There's an end around by NAMSP in particular. 2017, Congress passed this act. It took 3 years and multiple calls from many in Congress to even get the rule out for public comment, and that occurred in 2020. And then there was this little thing that happened in 2020 that the DEA will say that it delayed them a little bit. They had 6 months after the public comment to release the rule, and it took them 6 years to get that final rule out. And so some of the important things on the rule, and as Jathan said, it does create a EMS agency registration. So currently in the state, we have 2 methods that you can register your agency. One, it could be under your medical director as a practitioner license. And the second one, Idaho, just within the last couple of years, started registering agencies with the controlled substance certificate as a mid-level provider. So under the DEA, it was this mid-level provider. They had this ambulance thing, but it was the same thing that a PA or an NP actually gets registered as. So now the registration will actually be EMS agency. The provisions of this new act and this new law actually only pertain to agencies that are registered under that new registration. That's what legalists told us. The DEA, when we asked them those questions, they kind of looked dumbfounded that they even hadn't considered that. But so there is going to be a period of time when some agencies will be on the rule, some will be off the rule, off this new rule. And so your options, you can apply now if you want. You can transition immediately, register your agency, get an agency's registration, or you transition at your next renewal. And if you're on your medical director, then you will transition to an agency registration. Now, the important thing for you hospital-based systems that are using your hospital DEA, you have to be hospital-owned and use your hospital DEA. This rule still allows that. So, Keisha, I think you won't have much to worry about. So, besides the EMS designation, some of the things this does, it does clarify some storage requirements. It establishes some documentation requirements that we just went through, but it also establishes tracking criteria. And we'll go through each one of these bullet points and see. And as agencies, you're going to have to figure out the tracking criteria, because that may actually be the hardest component of this. So, under the under the EMS designation, this will actually allow, and it clarifies that each agency only needs 1 registration per state. Okay. So large organizations that have multiple stations across the state, you only need one registration. However, that registration site is the site that you must take delivery from your pharmacy or wholesalers or, Boundtree and such. That's where your drugs have to be received. And then you can then distribute them to designated sites. Now, all designated sites have to be listed on the DEA record and they have to be listed 30 days prior to the drug being stored there. Okay? So this, unfortunately, is one of those things, and, if you're a agency or private ambulance company that has multiple stations across the state and you're used to just drop shipping drugs to each of those stations, you'll probably have to change that practice, or you'll have to register each delivery site with its own registration. Okay, that fee's $888. So you kind of have to weigh the risk versus benefit, your process of receiving and then having to transport those drugs across the state to other locations. Like I said, this is your shipping and your main cache address. So it specifically allows administration by standing order or by verbal order. And so it took care of that DEA issue with that. Now, this is direct wording out of that, some of the drug storage issues. And so drugs can only be stored at a registered site or a designated location or on a vehicle while it's at a registered site or a designated location or a vehicle that is on a call, okay, or actively in use. The vehicle must be locked at all times, okay, and unless it's parked inside the station. Before, the original rule actually said the ambulance had to be stored inside a locked station at all times, and when not on a call. And so a lot of the private agencies, or a lot of agencies that use system status, kind of balked at that a little bit, because it was like, well, we've got our crews sitting on street corners while they're not on a call and such. And so they kind of verified and clarified that it was actively in use. It was okay to have the drugs stored there. You can put them in a jump bag or on a person only during an emergency, okay, or when you're actively on a call, but otherwise they need to go back into a substantially constructed cabinet or safe that cannot be readily removed, located at a permitted storage site, including that registered site or that designated site. You can use a NARC box automatic dispensing system as well to be compliant with that. Okay. That whole jump bags on person carriage. When I was flying, my flight nurse, she used to carry all the NARCs in her ankle pocket through the entire shift, right? They were never locked up. They were locked in, basically they were zipped in the ankle pocket on her flight suit. Under this new rule, that would not be allowed. So, okay. Administration, we kind of went through this to where you can use standing orders. You must document the last name or the initials of the authorizing physician. Now, this was actually a compromise. When the original rule came out, the original rule said that the medical director, whoever authorized it, was going to have to initial every drug delivery that was performed of a controlled substance, much like we do in the hospital with all of our orders, where we have to, if it's a standing order or a verbal order, that order eventually gets kicked to us and we have to sign it. They wanted to do that as well. And so you can only imagine your medical director having to go through the number of calls with controlled substances and click and sign every single one of those orders. So instead, they put that, okay, we won't make them do that, but you at least have to designate who authorized it. So the standing orders must be kept on file at the registered location. So if you're using state protocols, things like that, a copy of those protocols needs to be on file. You have to maintain everything for 2 years. The other one, if you happen to have like a verbal order from ER physician for online med control, or you do an interfacility transfer and the physician gives you some orders, then you have to add that physician's name onto those orders for any controlled substances. Anything you do outside of protocol, you add the other physician's name in there. Record keeping. This is probably going to be one of those big deals. So, and I'll kick down, the agency must maintain in readily retrievable form, okay? It means you can't go through and pull out a folder and go fishing through a whole bunch of files, okay? Documentation describing each professional's authority to administer, dispense controlled substances. Basically, these are your protocols. This is any state law that allows it, so scope of practice and things like that. You must keep a complete record of all controlled substances received, administered, transferred, and destroyed, and records must be kept at each registered and designated location that handles those controlled substances. Okay? So in other words, and it was funny because I talked to the DEA in January this year and asked them about this rule coming out, and they were like, well, it'll come out sometime, we don't know. And I said, yeah, I'm a little concerned that, you guys are going to put this, you want to account for every milliliter of that drug. And the lady was like, oh, well, we don't get into that level of detail. It's more about security and that type of stuff. And then this rule came out, and I can't wait till I see her at the next conference and get a chat with her again. But what your record actually has to look at, you have to have the drug name, the form, date, amount administered, and disposed. So the record that you use has to have the really a drug identifier with that. Has to have the patient identifier, last name of the name of the paramedic administering, the name of the physician, and then the manner of disposal and identities of disposer and witness. Those all have to be recorded and tracked and stored. Okay. The other thing too, this does allow EMS agencies to restock from a hospital immediately after a call. The 222 form is not required, which is pretty awesome. However, there must be tracking, and it must be documented within 72 hours if they receive, if a station receives narcotics from the hospital for restocking, that designated location has to notify the registered location, and there has to be tracking of that drug into the drug inventory system. Okay? And I can tell you, I think that would be a nightmare to try to do some of that. So, this is the main aspect of this. I think what a lot of agencies are going to need to look at is automatic dispensing systems, NarcBox, LogRx, other type products that you're able to actually track, record keep, and keep track of administration, but also waste. Okay, and there needs to be that reconciliation that goes on with that. So these are the main elements. Anyone have any thoughts, comments?
Dr. Sandy?
Yeah.
Could you return to the storage?
Yep. So basically what you have one registered location, and that's where you receive delivery of all your narcotics. That's the official, right? Then you have designated locations. Those are your stations. It's a hub and spoke model. So
Dr. Sandy,
yep.
talking about with storage, sometimes on like the wildland deployments, when we go out on wildland, if we take an ambulance, we've got a safe in the ambulance and can keep that locked.
Yeah.
Is there any kind of provision or any kind of guidance for if you happen to send out a line medic that takes a medic bag and is out on a fire line, not near a vehicle?
Yeah, so what you can argue is that jump bag, that would fall under the jump bag. It would follow under that jump bag on person carriage, but the minute he's actually off the line and not actively engaged, he would have to have the ability to lock those drugs up. So,
yeah, Dr. Sandy, we have a question in the chat too from Brian. What if the wildfire medic or ambulance has to cross state lines?
Yeah, good luck with that. Yeah, the DEA is pretty clear that narcotics are your registration is only good in one state. And so to be fully compliant, your agency would have to have a DEA license in each state that you're going to deploy to. The problem with that is trying to find a registered address for that remote state. So, yeah, it's the entire rule is silent on that, but the DEA has been pretty clear that if you look up further in the rule and such, that it's a state-specific controlled substance use and accountability are a state-specific process.
So then would that be the same for long-distance transfers that go down to University of Utah?
Well, they would say, something like that. You could most likely, because you are traveling to and from while responding to an emergency or otherwise actively in use, they would deem that that's a continuation of, you're in your home state, you're going to an outside state while actively providing care is a little different than going into a standby in a remote state without an obvious patient or actively involved in emergency care. So,
couple more questions in the chat, Dr. Sandy. One from Brian again. So Idaho will not be taking teams from out of state to help with wildfire season, or they would only come without controlled substances, correct? Our stance at the EMS Bureau is that we do not interpret or enforce DEA regulations. That is completely up to the DEA. So we would not have a part in making that decision or enforcing DEA rules. If the only things we would enforce are what appear in our Idaho statutes or our IDAPA rules, which do not contain any of this stuff. And then another one from Dan. If our agency is based in Washington and we are sent on a wildland deployment to Idaho, are we not on an emergency call the entire time? That seems to be the entire deployment. Is one call. Thoughts on that?
Yeah, I think the thoughts are, I think the DEA would look at that very differently, but, the DEA is the one that's going to be monitoring and regulating the cross-state movement of these drugs. And so, really, unless a board of pharmacy who maintains the controlled substance registration or the DEA, unless there's an issue, the DEA could decide they want to get involved with it. I'd hope they wouldn't, but, the provision of the rule is exactly this. It's silent on wildland fire operations. If you can get a disaster declaration, then, the rules basically get suspended and you're able to do a lot more that way. But that usually doesn't happen on routine wildland fire operations. So I think you're going to have to, the biggest thing for agencies, and the one disclaimer on this is you're going to have to get your own attorney to interpret and guide you on full compliance. Whether you're city attorney, your county attorney, if you're private, you may have to get legal opinion on your operations to ensure that you're in compliance. So.
Yeah, Dr. Sandy, do you have access to open the chat from your end? There's a few more questions in there that
let me look.
You could blend them together. That would be the best to answer them.
Yeah, so the interesting thing, so on JD's question, drugs not registered to the state specifically, they actually are to a certain extent, because wherever you receive it at your registered location, because it will be ordered to your registered location. Okay? Now, if you are an agency that has multiple state DEA registrations, then much like you transfer from a registered site to a designated site, you should be able to transfer from a registered site to a registered site as long as your tracking is in place. Okay? You would have to record where that drug went. It went from this to this site, and then it was delivered to this patient, and then this much was wasted with this witness to the waste, and how was it wasted. And so, you should be okay from that standpoint, as long as you have those registrations in multiple states. So. AB, so that's who did you have a call with the DEA, and which office was that with?
The meeting was actually with Viper.
With Viper?
With the ALS ambulances. It's not a minimum requirement per their contract, because they understood that you couldn't cross lines with it.
Yep.
Also, Dr. Sandy, we've gone through this process at Victory, and did it about 2 years ago. We actually had to get a resident drug outlet registration with the Board of Pharmacy prior to getting our DEA license. So
Correct.
that may be something that these guys have to do. And then
Yes.
with that too, I know the inspector that we've had at the DEA has been very helpful in giving us feedback and ways we can improve. And so there's a lot of documentation that EMS probably hasn't been doing that we should have been doing in the past that they'll help you learn. It's not like they come in with guns blazing and ready to arrest anybody that's violating the rules. They really do help try to make this as seamless as possible. But I think the advantages that we fail to look at is if for some reason you do change medical directors, the process is very seamless because you're no longer held to that medical director, and so the narcotics is the agencies themselves, not the medical
Correct.
directors. So there's no need to do that transfer of meds and try to figure out that whole mess that's happened in the past.
Yep. Yep. It is. It is. And, and this is the one thing where the agencies are now going to be 100% responsible for the controlled substance. It won't fall on the medical director to, provide any oversight or anything like that. The only requirement for the EMS agency is they have to have a medical director per this DEA rule, because they have to have an authorizing physician on the protocols. So. Yeah, so Dr. Curry from the Forest Service also believes that you don't need a state license to practice EMS on a wildland fire or a forest fire, and that a national registry card and their Forest Service credential is adequate to do that. So once again, we've gone back to the 1990s on wildland fire. So we are based in Idaho, but have a contract ambulance in Washington. Do I understand it that as long as the ambulance station in Washington has a locked narc box when on calls and gets its drugs from one central location, then it would meet the intent of the rule? It could, however, where your designated location, right up here, number 2, is not in the same state, the DEA and the state of Washington may require you to have a registration within that state. So, as was mentioned, Idaho is one of few states. There's about 20 states or so that require EMS agencies to get a controlled substance state registration as well. And I know I've talked to Nikki over the past couple of weeks. She's over DOPL and the Board of Pharmacy, and they've been using that dispenser outlet criteria, even though the pharmacy rule and our EMS rules really are silent on any of this. But yes, your first step is to get your state certification or your state registration. Once you get that, then the DEA will issue you your agency registration. If you go to the DEA first and register, they will tell you that you have to go to the state and get that registration from the state, and then they'll issue you your federal registration. So, okay. So you will see, I know NAMSP, I know there's several, I think NAMT, there's several national organizations that are doing webinars on this as well over the next couple of weeks. And at NASEMSO, I can tell you, we put a bunch of questions in to the DEA when this first came out for clarification and such. And they have been pretty quiet to tell you the truth. We've really not heard back much. When I talked to the Boise folks, very nice, but they too are just like, yeah, we just got notice for it, and we're still learning what it is and those processes and such. So hopefully we can get into everyone on the same page with processes, and that this will just be streamlined and such. But, understand that you can transition now, or you transition when you renew your current registration. And so the one thing to remember is that you have to do your designated locations 30 days prior. So don't be renewing the registration and applying for this the day or, a week before that expires. Actually get the 30 days in so that you can be totally kosher with that 30-day requirement for the designated locations. So, yeah, and Travis put that application in there, which reminds me, all mine expire in 3 weeks, so I have to renew all my state stuff. So, okay.
Dr. Sandy, I wonder if I may jump in with a quick question. Apologize for another. My name is Joe. I'm with Tamarack Ski Patrol, and we are actually an ALS level ski patrol.
Yep.
And I'm sure you can imagine the setup of carry options in that situation. So I don't really see how to avoid that, which is why I bring it up with the group here.
Correct.
So I guess would carrying it on person, even if I put a breakaway tag on a zippered pocket, would something like that cover the jump bag portion of things, or do we need to go fully on to storing narcotics top of the mountain? And then that's where I see another hiccup, because if my paramedic patroller is not, let's say he's at the middle of the mountain and the call is occurring below him, well, he's obviously not going to go to the top of the mountain and then go get his narcs. Then we're in the standpoint of an EMT bringing him.
Yep. So I think in the world of common sense, to tell you the truth, in a situation like that, I think you have a central locked location that is your registered location. All your narcs are checked out from that location at the beginning of the day. I would suggest, and this is just me personally, I would suggest that you figure out a deployment model that the narcs go in something that is sealed with a tamper-resistant tag that is logged, and then you check it out to that patroller, and at the end of the day, when he comes and checks back in, that log gets rechecked, and it goes back into the safe at night. That's how I would set it up personally. I think that you could argue that would be in full compliance, because you are actively in use, you are actively working. It would be the same thing as the wildland fire. You're out on the line, you're on duty. It's not reasonable to have to go back to a locked vehicle to go and get the drugs, that type of stuff. But if you show that you're taking safeguards and putting those safeguards and those guardrails into place, if you were just handing them, Briscoe-Jets of morphine and such, and they were just putting it in their pocket, right?
Understand.
Now, yeah. So there's a little bit difference with that, but I think that you could argue that process would be appropriate, as long as you have that security in place in the storage area, and then a way to monitor it when it's out of that storage area.
Okay. Understood. And for what it's worth, I can 100% appreciate the common sense response as well. And fortunately, that seems we're in compliance so far. So great. Thank you.
Yeah. That's just me. Every DE agent is going to be different, but yeah.
Okay. Well, thank you again.
No problem. Okay. Any other questions? Burning topics? Okay. Yeah, Travis.
Hey, Sandy, this is Smedley up in Idle Falls.
Yeah.
So I couldn't get onto this call until just about 15 minutes ago.
Yeah.
Is there going to be a place where there's a nuts and bolts of this conversation, or that I can review? I'm sorry for being late. I just couldn't get there, but
No, you're all good. We understand, Jerry. We understand.
No, yeah, we've recorded this conversation and are probably gonna put it on YouTube and put a link to it on our website. It'll probably take us a couple of days to get it posted, but we did record it for this reason that a lot of people wouldn't be able to make it on. So we'll make it available and let you guys know.
thanks.
Yeah, and so remember the disclaimer, I'm not an attorney. I did Holiday Inn Express last night, however, but agencies, if you have big questions and such, seek your own legal advice, get your county, your city attorneys involved. So
I did have a question regarding our PCRs. And what's the best way for us until our reporting company gets caught up to date like the iGEMS has? What's the best way for us to document it? Is it just put the state protocol in our narrative and the doctor's initials in the narrative as well?
Yeah, I don't. So truthfully, until you have your full registration, you can say that, hey, I'm not registered as an EMS agency, so I don't fall under this. And I've had attorneys tell me this in other states that that until the agency is registered, these rules really don't pertain. But what EHR do you guys use?
We're using ESO right now.
Yeah, ESO just sent an email. I just got it today with instructions on how to do this exact thing in your configuration. And they are actually doing a configuration change that will go live on the 13th this week with all of these changes in their system.
Okay,
and
that's good to know. I haven't got that yet. So
yeah, my supply dude out of state sent it to me and said that he actually got it yesterday. But my EPCR guy got it yesterday and sent it. And so, yeah, I've not heard anything from First Due. So, Ryan, I don't know if you're still on, if you've heard anything from them as far as configuration changes. These are all NEMSA data sets and NEMSIS elements, so it's real easy for them to do. They just have to activate it and go through that process. So it's not like they should have to create new code or anything like that. They should already be here. So you should know, too, that there is actually some controlled substance tracking available within the PCRs as well. And so you can turn that on, and it'll actually keep track of all your wasting and your drug delivery. And, it requires that they put the waste in there as well. So.
thank you.
Yep.
Okay. Any final questions for Dr. Sandy or for us? I just want to reiterate that the Bureau is not in the doesn't enforce DEA regulations, and we don't interpret DEA regulations. So, for down and dirty specifics on whether something is compliant with this new DEA rule, unfortunately, you're going to have to get that information from the DEA. They do have a local office, so it's, talking with us, we just cannot do that. So just wanted to make sure that was understood. Also,
in other words, don't call the Bureau if you have questions about this, because they'll just refer you to the DEA.
Yeah, that's putting it in a very nice way. Yeah, we're actually prohibited from interpreting federal regs. So, but anyway, I have seen quite a few people logging on late in the call. So if you missed the call, then we did record it, and we'll be popping it online. We'll have a link to it on our website, and it'll probably be in YouTube. But if anybody doesn't have any further questions for us or for Dr. Sandy, looks like Cammie just put a question in the chat. Dr. Sandy, does this affect the medications we are allowed to carry per our medical director? I would assume that answer is no.
No.
It's in your protocols.
Yep. None of that changes. You still, do the purchase with the 222 form. It's still medical director. Under the scope of practice, it says medical director approves the meds. So, yeah. Good. And Steven says First Due had a schematron out last week. Good.
Cool. All right. Well, thanks, everybody.
And, hey, Patrick, a good DEA contact. It's a good question. When I called, I just called the office, and they just kick it to one of the field investigators, whoever is on call that day. So that's who I talked to at the in the Boise office. So.
Okay. Well, thanks everybody for joining.
One question. Sorry, apologize for interruption. This is Josh Farr with Harrison Ambulance. If there'd be any way that I could stay on for just a brief moment with Dr. Sandy, or Dr. Sandy, could I give you a follow-up phone call here? Just take a minute.
Yeah.
Yep. We've got time. You can stay on. That's fine.
Okay. Thank you so much. Sorry for the interruption.
No, not at all. Well, thank you everybody for attending, and drop off as you feel necessary. Thank you.